Good evening. Welcome to this session on surgery in the elderly. It's a very important topic because even in the Indian scenario, the number of patients who are in the elderly age group is increasing steadily. It's been a long issue in the Western population for a long time, but even here, this is becoming an important thing. And a lot of what we are going to learn and discuss today is common sense. Of course, common sense, it has been put into numbers through studies. And so what I'm going to tell you is all evidence-based, but a lot of it is common sense. And you will find that a lot of it that we know and we discuss is actually not practiced in life. And the real message from this talk would be that we must practice this in life. We must look at all these things in a very objective and a scientific manner and carry it out in our daily practice. If you watch any of our practice closely, you will find that while we may not be basically filling up forms and getting scores and things like that, which is even more scientific, but the principles that are brought across in those checklists and forms and things like that are practiced in everyday life. Our decisions are based on those things. Okay, and so we will then, in the next hour or so, learn what is it that is special about surgery in the elderly. All right. So we start with a very simple thing. Who are the elderly? Is there a clear definition of this? All right, Samir.
Yes, sir. The elderly or a senior is defined as a person who has uh, age 65 years or older, sir.
Okay. Are there any other further, you're right, any further definitions? Is there a thing called super elderly? Have you seen papers saying surgery in the super senior population? Is there a number given to that?
More than 85 years, sir.
80. Okay. More than 80 is super. And interestingly, in
Young and
trauma, the threshold is taken as 55 years. In the World Journal of Emergency Surgery guidelines, they say that the effect of trauma in the aged is significant, and so their threshold in defining the elderly is 55 years. But we must all remember that this is practically fiction, in my view, because there's a world of difference between chronological and physiological age. A guy who's 50 may be, chronologically 50, but he may be physiologically 80. And a guy who's 80 may be physiologically 60. And so what you have to do is, while you do bear in mind the age of the patient, the old adage that age is but a number still holds good. We must be aware of the special considerations in the elderly, but age itself cannot be a decision-making factor, at least a major decision-making factor in your decision to do surgery or otherwise. That is the important message that I would like to give here. Okay, so the question is asked, should we operate on the elderly at all? Age is a risk factor. There is no doubt about it. But sometimes, in fact, many times, the operative benefits far outweigh the risks. And so it is not required that you do not operate on the elderly. Also, you must note that prognosis is worse in emergency surgery compared to planned surgery. It is true for the younger age group also. Any emergency surgery carries up to 5 times higher morbidity and mortality rate than planned surgery. That's why we keep saying in hernias, get it done before it gets obstructed. Here is evidence for that. There are many more, and I'm giving you a representative paper, 4,000 emergency operations. Mind you, we have said that emergency operations carry more risk than planned operations. Of the 4,520 over 80 years of age, super elderly, they had a mortality of 25 to 30% in major operations. Supramajor, you can call it, like big time bowel resections, pancreatic necrosectomy, aortic aneurysm surgery, things like that. They had a mortality up to 30%. which is significant, but still look at it the other way. 70% survived. Okay, how did they survive is a different question that we will address that as we go along, but they did survive. This is a 30-day mortality data. And if you do a small operation like a non-strangulated, no bowel resection, but an obstructed hernia, for example, there was no mortality in this series. So it's clear that just age should not be a factor on which you would deny a patient surgery, but look at it in a pragmatic manner. And how do you look at it in a pragmatic manner forms the substance of this discussion. All right. So if you say you can do it, we also said that there are special considerations. What do you think these are? Nikita, just give me a list of what you think you would first
Sir,
think
special
of.
considerations would be the patient's intention, sir, like
Very
the
good.
living will and the
Goals of
advance
surgery.
directive goals.
Very right.
Yes, sir.
Goals of surgery. Okay, very good.
And nutrition,
Good. Yes, nutrition is another concern.
preoperative fasting or nutrition, and
Yes,
medication, sir, current medication, what they are
correct.
taking,
Correct.
medication management,
Right.
and
Most important one, ma'am.
the post-op complications, sir.
All right.
No.
What else? Yeah.
You omitted the most important one.
Hi, Ravi. Welcome. Welcome. Yeah. Tell them, Ravi. Tell them what you think.
Comorbidities. I think
Yeah.
that is the most important consideration in any
Elderly
age group, especially elderly.
Right. Okay. So what you're looking at is, yeah, there are physiological changes. We must realize what those changes are. That's how you treat an elderly surgical patient different from a younger patient. You must talk about certain catchphrases in the elderly, and the leading catchphrase is frailty. Okay, frailty. Comorbidities, as Ravi mentioned, and you already mentioned the other two, social issues and medical legal issues, which are basically advance directive and withdrawal of treatment and things like that. We'll touch upon it as we go along. Okay, but what is important is that when you're talking about elderly, these are the common things that you must understand: frailty, delirium, fall risk, functional impairment. And in this talk, I'll say a little bit about futile surgery, which is important to learn, but we will talk a lot more about it in the next class on professionalism and ethics. Okay, so we'll just touch upon futile surgery. So remember, whenever you talk about surgery, you must think about frailty, delirium, fall risk, and functional impairment. Extremely important. Okay, so we said physiological changes. All right, Praveen, tell me, what are the physiological changes that you will see system-wise? I'll make it easier for you. Make it compact and orderly. System-wise.
Cardiological,
Yes.
low ejection fraction,
Yes.
decrease in preload,
IHD and
yes.
failure. Okay, go on.
pulmonary increased PAH, sir,
Okay.
and decreased lung capacity, sir.
Yes, correct. Next system.
Endocrine, due to comorbidities like diabetes, impaired glucose metabolism,
Right.
decreased renal function.
Yes. Yeah, you must understand cardiovascular and respiratory. You mentioned musculoskeletal. They have joint pains, they have incoordination, and because of sarcopenia, they do not have the power, and so that leads to higher, fall risk, which makes things worse. You may have done an excellent hernia repair, and if the patient gets out of bed that night and falls, then you're now left with a much bigger problem of a fractured neck, femur, or whatever else. Okay. What about the GI system? Common
Gastric
problem.
emptying.
Okay, gastroparesis.
Motility,
Okay.
sir.
Yes. In the elderly, what is the first
Absorption,
complaint?
sir.
What is the first complication?
Decreased
that
appetite, sir.
much more common than that
Constipation.
thank you. The first thing you hear about any elderly person is constipation. Okay, so that is the first thing. I agree, gastroparesis and dysregulation, lack of appetite, bloating, all this occurs. Nervous system?
Cognitive
Decreased
decline.
neurotransmitters, sir.
Yeah, clinical elema, we are neurotransmitter. Am I seeing serotonin? No.
No,
Clinically,
sir.
what happens?
Decreased perceptions.
Correct. Confusion, cognitive impairment,
Impairment.
okay, lack of coordination because of perhaps ischemic brain disease, cerebrovascular disease, or Parkinsonism. We mentioned about renal, we mentioned about endocrine. Tell me about skin. What happens?
Atrophy, sir,
Loses.
skin atrophy.
Yeah, what does it lead to? You're right.
The temperature instability, sir, because of low
Yeah.
fat.
Correct.
Early
That is
breathing, sir.
thermoregulation, which I mentioned down here. Yeah, skin healing is impaired. So practically, you may want to leave the sutures in a little longer. Okay. Immune system is affected. Sensory. What are we talking about when we talk about sensory?
Diabetic neuropathy.
Neuropathy is one. What else?
Vision and hearing.
Vision and hearing, which can be very, very. So, as I said, most of this is common sense. We see it every day, but we never think of it. That is the purpose of this discussion is for us to think about it. All common sense things, because if you operate on somebody and you're not aware that the patient has impaired hearing, or you're not even giving attention to it, then he will not follow any instructions. So you have to take compensatory methods. You will have to either talk to him into the ear, or make sure he wears his hearing aid, or tell an attendant what needs to be done. So this kind of attention has to be given for you to have successful surgery. That is the important thing. I mentioned about frailty, and instead of asking you, as you can see, to save time, I have put some answers myself, so that we will cover the whole thing within an hour, hopefully. Frailty is something that is very commonly used. We can, that person is very frail. What does it mean? How do you measure it? How does it impact on surgery? Is what is important. So it goes just beyond disability. That's the important thing. This person, has a stroke. He'll be frail, but that's not it. It'll have many, many other things like cognitive disability, risk of falls, and it has been shown that when you have graded, I'll show you what grading is. This is a global scale. When you have graded them, those with the higher grades of frailty, it's been very clearly shown that they have poor outcomes and death as well, higher mortality. So when you're dealing with an elderly gentleman, it's very easy to have a global scale. There are many, many scales, mind-boggling if you look at the literature. I don't think we should get confused and we'll get lost in our focus when we look at all these things. These may be global scales, it may be country-wise, different countries have different scales, it may be disease-wise. If somebody has a major comorbidity as, say, a cerebrovascular disease, then there is a frailty scale for CVS, there's a frailty scale for cardiovascular disease, so for a neurological disease. So let's not get complicated there, but I'm going to show you one simple global scale, which all of us can do as we walk into the hospital and just talk to the patient or his attendant. Okay, so this is a simple clinical frailty scale, which can be applied everywhere. And you can see that from being a very robust person, at grade 1, you have a grade 9 terminally ill patient. So for a surgeon, the important things are the 4 and 5, because you will learn as we go along that this scale may get worse after surgery. So a guy who is in 5 may suddenly become 8. All right. And that is for the post-op period. But in the pre-op period, your decision to do the surgery at all, grade 7, 8, and 9 are important. That's all we need to understand in this. If somebody is very dependent on others for daily activities of daily living, then you have to think, what am I doing by doing this surgery? And that issue will be raised again in the last slide, where I'm going to briefly mention about futile surgery. So grade 4 and 5, you do not hesitate to operate. but you have in mind, and there are methods to, very simple common sense methods to avoid the worsening of the patient's condition. Okay, we should put them back in a better or at least the same state as they were in before we operated on them. And our operation should not make them worse as far as their daily living activities are concerned. That is the goal. Okay, so 4 and 5, perhaps 6, you are worried about making them worse, but in 7, 8, and 9, you're more concerned about whether you should do surgery at all or not. Am I clear there?
Yes, sir.
Yes, sir.
All right.
Please answer every time.
Yeah. So, how do you know? You talk about frailty and dependent on others and things like that. What does it mean? You have very simple. The ADLs are activities of daily living, and one level higher than that is the IADL, which is the instruments of activity of daily living. So, in activity of daily living, simple things. Is he mobile by himself or with a crutch? Can he feed himself? Can he wash himself? To go to the toilet? Does he dress himself, or does he need somebody else to button his shirts? Okay, washing, transferring. You're going from the bed to a chair or from a chair to your toilet. How do you manage that? So there is some overlap between transferring and mobility. And the instruments are a little more important as far as cognitive function is concerned. There's a lot of thinking, there is some calculation, not only just physical existence, which means that can he cook for himself? Can he manage finances? Can he go to the bank or do an online transaction? Can he clean his own house? Can he go and use a public transport? Okay, so you can see that all these are common sense questions and common sense issues, and we can do all this in our everyday life. As students, students of DNB or MS, for example, you can even document it. Even though if you sit with me in the outpatients, you will find me asking such questions of all the family or the patients, about ADLs and IADLs. I actually ask them and make sure that these things are done and they are in, grade 4 or 5 at least of your global scale before I operate on them. So it's something that we can all practice in everyday life. Fall risk, as I told you, is another very important thing. Not only in surgical patients, in any elderly, when they come to the hospital, there are some structural changes you need in hospitals. This must be there in all hospital rooms, in my view. It's not so in many places. We'll discuss that a little later. But even then, if you have an elderly coming in, you have to have very simple 3-step evaluation, which is a history. Have you fallen before? Do you feel unsteady when you walk? Physical examination. Do you have any particular weakness? What is your grade of power? When you most often, if you check at all, check the vasti. That's the most important thing, for some person's fall risk. If somebody has a very weak vastus, the whole of vasti, in fact, then they have a higher chance of falling. Do they have foot problems? Can they see well? If they can't see well, even if their legs are powerful enough, they'll fall. Okay, and medication, are there any sedations or any kind of psychotropic drugs which can cause cognitive impairment? So every elderly person over 65, and I qualify for that, so you must take this history if they come up for surgery. And there is one comprehensive geriatric assessment which is done, which takes all these considerations, all these under one simple assessment. Okay, if we talked about the functional assessment, Ravi has rightly mentioned the big comorbidity, nutrition, mood, drug history, environmental conditions. What kind of conditions does he have at home? What kind of support does he have? And what is the cognitive support, cognitive status? So this is a picture that all of us can remember. And I'm sure it's not difficult for us. You can start it tomorrow. Make a note of under each one of these what the status of your elderly patient is. And when you have, there are many studies. I've just quoted one Cochrane review here that when there are scales for this. So if the scale is good, which means that the condition is good, there is reduced mortality and a higher chance of return to previous state. As the scale worsens, as the patient loses more than one or several of these factors, then mortality is higher and there's a lower chance of him getting back to the kind of pre-operative status. Okay. So this is in preparation, in general terms, for a patient before you undertake surgery. But for surgery itself, you need to think of major issues in the elderly in these terms. Nikita mentioned it. Increased post-op complications are common. Functional decline is common in spite of a good operation, and loss of independence is common. So before you undertake surgery, you must have this in mind and make sure that arrangements are made for proper rehabilitation of the patient after surgery, because you do not expect them to get bounced back like you would expect it of a younger patient. So the steps towards safer surgery are pre-op, intra-op, and post-op. At every step, certain precautions have to be taken. There's a very nice monograph of guidelines in surgery by the American College of Surgeons, 2018. Most of what I have to say from now on are from that monograph, which is a very, very nice thing, and I'll attach it in our group, and I think you guys must go through it. It's a very, very good thing. But again, an important point that Ravi made, we look at all these common sense things, frailty and fall risk, etc., with diligence, I agree. But the first important step is for you to have a thorough cardiac and pulmonary assessment and optimize the condition in elective cases. In emergency cases, you have no choice. But in elective cases, optimize these two systems as much as possible before you operate. Okay? So we talked about social considerations. What are the things that you think you should have in mind in terms of social considerations? I'm talking about not just social, pre-op assessment, including social. Okay, Praveen or Vinod, maybe. Vinod, tell us about it.
Sir, all the pre-operative I have to tell, sir.
Okay.
All the pre. First of all, for the fitness of the patient,
No, especially in the elderly, I'm asking.
Yes, sir.
Yeah. We talked about comorbidities, you are going to address it. What else would you consider?
Whether the family support to the patient is present or not.
Good.
And whether patient anxiety, any depression.
Correct. Mood, anxiety, depression. Anything else?
And nutrition, sir, most important.
Yes, very good.
And most commonly, older ages, quite common is with anemia, the patient might come.
Okay.
And renal things.
Yeah. All right. So the important thing which you didn't mention, you said social, family support and all that. But the thing that Nikita mentioned earlier, we must understand the goals of treatment and the patient's preferences. I agree that in this country, this is not very common, but I have tried even in my daily practice to know what is it that people want. And if you ask a leading question, many times you will get a good and correct answer, even though they don't offer it themselves like they do in the West. Okay? You must look for and ask for who the surrogate decision maker is. Okay? Also look for advanced directives, if any. These are very important. Not so in this country, I must admit that, but it is very common in the West. But this is coming. The trend about advanced directives is coming. I know of at least 5 of my own family members, my uncles, things like that, who have all given advanced directives. Okay. So consider shortened fluid fast, 2 hours should be enough. Adhesion to best practices as far as antibiotic and venous thromboembolism is concerned. Embolism is commoner in these patients. And look at the medication. That's another important thing. A medication list, many of them will be unnecessary. So even though I don't deal with it myself because I'm not an expert in that field, I always get my physician to review my elderly patient's medication list. What should be the intra-op checklist? What is it that you would prefer to do intraoperatively in these patients? Do and don'ts in the intraoperative phase. Nikita.
Sir, intraoperatively, initially it will start with anesthetic approach, sir.
Yeah.
Then the
What is the
preoperative
approach?
pain management.
What is the
Sir,
approach?
are we choosing general anesthesia or the regional anesthesia?
What is better?
Evidence that shows that both are equal, sir.
Okay.
But if possible, we could go for the regional pain management techniques, sir, like epidural and extra things, which don't
Okay.
alter the sensorium of the
Would
patient.
everybody, Nitya, do you agree that the risk of regional and GA is the same in the elderly?
No, sir. I would say the regional is relatively better compared to
All
the
right.
GE.
Okay. Any other, I'll show you the evidence. Yeah. Any other things, Nikita?
And post-operative like fluid management during the surgery,
Okay.
sir.
Okay. Pain relief during surgery?
Pain. Yes,
What
sir.
yeah.
Pain
What is
control.
it? Yeah. What would be your preferred approach?
Sir, multimodal approach, and we have to minimize the use of opioids.
Yeah, that is the important thing. Okay. So anesthetic
Yes, sir.
approach, regional techniques are safer than GA, but in case GA is required, you can use it. It's not prohibited. The other advantage of regional is that, like an epidural, for example, it also helps you in the post-op pain control, which in a GA it doesn't work that way. Okay, peri-operative analgesic pain, multimodal, but always opioid sparing. That is the important thing. Opioid sparing, use regional techniques so that you don't have to give intravenous medication. Always think of post-operative nausea and vomiting. All right. And in longer operations, particularly positioning the patient. These patients are frail. They have little subcutaneous fat, little muscle, sarcopenia, and the pressure points. You have to give better attention to pressure points in the operative time itself. And fluid management you mentioned, which is correct. So it's better to run them a little dry rather than overloaded because they will have reduced cardiac reserve. So what are the advantages of regional anesthesia? Sorry, go on.
One more point which you have actually mentioned there, hypothermia, because elderly people are more prone to being hypothermic.
Correct.
So you have to use warm blankets and things like that, warm
Correct.
IV fluids.
Very true. Very true. All right. What would be the benefits? So I've already mentioned a couple of benefits. Okay. The morbidity is less. Post-op analgesia is another possibility. Is there anything else? Can anybody add anything to that? Those two?
Requires less amount of normal painkillers, sir.
All right.
And less risk of thrombosis.
Yeah. Yeah. That's true. Correct. Okay. So the two things that you could add to that was reduce risk of thrombosis and reduce mortality. People have shown a 30-day mortality be less with regional anesthesia. That's why I said it's a little safer, okay, than otherwise. And because there is no instrumentation of the airway, their post-op chest complications are a little less. Okay. There are also some reduced post-operative confusion that is probably secondary to the lack of use of all those anesthetic agents which can cause more confusion. All right. So that is the advantage. And of course, if you, after giving regional, if you use opioids and things like that, this last advantage may not be there at all. Okay. And it can also be used as analgesia, as I said. And in addition to, I'll run through this to save time again. In addition to the lack of confusion, you will have quicker return to bowel function, okay, reduced cardiac complications, decreased hospital length of stay, and the need for sedation is much less in these patients. Apart from confusion, one of the things that we are worried about is delirium, very common. So this has an advantage. Nitya, you want to say something?
No, sir. I agree with it, sir.
Yeah. Okay. All right. Okay. So we also talked about PONE, NV, which is post-operative nausea and vomiting. Ines, tell me some things that you can do to avoid the PONV.
Sir, we can make sure before taking them up for the procedure to give them adequate amount of antiemetics,
Okay. Prophylactic antiemetics done. Okay.
And like even after the surgery, sir, to ensure that we are giving them adequate amount of like pantoprazole, PPI, sir, along with the
PPIs you think
antivirus.
will avoid it? Okay. May not be completely true. See, you must keep your answers short and crisp. So instead of going around, they just say, sir, I think we should give them pre-op antiemetics,
Antiemetics. Yes, sir.
intra-op PPIs. One phrase, not even a sentence. Go on, next. That's what impresses examiners. We know that you know. Yeah. Okay.
These.
So the things are that if you use volatile anesthetics and nitrous oxide, you must try and avoid using it. Regional anesthesia is one of them. That's how you do it. Avoid opioids. And if you have long duration of surgery, you can't avoid it. If the operation demands it, you have to accept it. That has increased post-operative nausea and vomiting. But if you have typically to reduce the duration of surgery, it's better. So don't train residents on elderly people. That actually practice it. If somebody is frail and old and all that, I'll tell the guy I'm training, look, I'll finish this operation. Because well established that the only risk or only negative of training somebody is increased duration. It can actually be twice as long as you take it otherwise, when an experienced surgeon is operating. So increased duration is something, that's the point I was trying to make, that if you're operating on the elderly, the consultant will probably say, look, let me not train you on this, I'll do it myself. Okay. And so, as you said, PPI, I don't think has a direct effect on PONV. Prophylactic, sorry about that. Yeah. Prophylactic antiemetics do have a role. Ravi, you want to say something?
Yeah, I think there is an adage which says good is better than best in certain situations. Don't try to do perfect surgery, especially if it involves a longer duration. For example, doing a very ultra low anterior resection and anastomosis maybe in the elderly taking a long time, and patients on stirrups and increased complication of DVT and chest complications and things like that. You have to weigh the risk and make sure that do it quickly as soon as you said, senior elder experienced surgeons, and do it as quickly as possible, but sometimes accept that it may not be the perfect solution in a given situation, but for that person it may be all right.
Yeah, well, that's very true. Very true. And my urology friend always says this. He does operates on an 85-year-old. And then he says, I'll just create an adequate channel for him that will last for the next 10 years.
Correct.
Okay.
Yeah.
And it's not that he completely takes out all the BPH. He just makes an adequate channel because he knows that he will not need a catheter. He won't go into retention in the next 5-10 years. By that time, the person himself is probably gone. So that kind of common sense and reducing the duration of surgery, mind you, them fluid balance is very important for urologists when they use this irrigation. So having a very long, big prostate, and so you keep on operating on them for hours together can be very, very detrimental. So that kind of individualization, as Ravi mentioned, is extremely important in your decision making. The other important thing I already mentioned, frail skin, no collagen, no subcutaneous fat, no muscle. So pressure sores are very common in these people. And apart from that itself, there are other inciting things like longer case length, hypothermia, cardiopulmonary bypass, positioning, which is in our hands, and the higher ASA class makes it much worse, and the use of vasopressors. When that happens, it shunts away the blood from the skin, for example, to keep your cardiac and cerebral flow going. And so you find that there can be relative ischemia and higher pressure sore. And that is something you've got to give attention to. What would be your post-op consideration? Go on.
Sir, can I ask you a question? For example, elderly patient, quite elderly, large inguinoscrotal hernia. Would you consider just doing under local or spinal and open operation rather than doing it laparoscopically?
Absolutely,
Because,
routinely
yeah.
I do that. I never give them GA, particularly large, higher recurrence rate with laparoscopy. So I do it under local anesthesia.
Yeah, I think that students need to understand that because laparoscopic surgery You have to tailor it to the needs of the patient and the conditions of the patient.
Absolutely, absolutely. Okay. Any questions or doubts so far from students? Any comments also?
Sir, this intraoperative, even when we are giving general anesthesia,
Right.
preferring propofol has a good because it has shorter duration and it has anti-emetic and anti-emetic actions also, sir.
Correct. That's true. That's true. Yeah.
Sir, can I make a comment, sir?
Yeah.
See, the situation in England was that because of the reorganization of services, vascular surgery was not available in all the hospitals. So there would be a local hospital. That day it would cover the 5 hospitals around that area. So if, for example, a patient who had a ruptured aortic aneurysm about 15-20 miles away, the patient is able to make the ambulance journey from that place to the place in question, and when they come to the hospital they are relatively stable, then you know that patient is likely to do reasonably well post-operatively. Another very funny anecdote was we had a 89-year-old lady in Scarborough who came with a ruptured aortic aneurysm, and she was relatively stable, so that was one point. And the consultant came and saw her, and we were about to shift her to the OT, and he said, look at her, she's painted her toenails recently and she's kept herself very well. I think we should operate on her. So at the eyeballing a patient at the end of the bed to see what is the gut instinct that you get by seeing this patient, whether they will do well or not do well. I think that is a very important consideration before you operate on these patients.
I agree. Agree. So what would be the post-op consideration? Is Sanya there? I didn't. You're not
Yes,
involved.
I'm here.
Sanya, come on.
Yes,
we
sir.
need to hear your voice, otherwise we miss
Yes.
you. Yeah, go on.
Yes.
What are the post-op considerations?
Yes. So to start with, immediately post-op, I would make sure that the patient is like there's no hypothermia for the patient.
Yeah.
If the patient, since the patient is NPO, is adequately receiving IV fluid, and patient's pain is taken care of.
Very good.
Patient, especially in the post-op period, when patient is out of the GA but not completely awake, make sure that all the side railings are put so that there is reduced fall risk. Then eventually make sure once the patient is allowed orally, nutrition to be taken care of.
Yeah.
If an abdominal surgery is done, then his chest has to be taken care of with incentive spirometry or chest physiotherapy.
Good.
And eventually when the patient starts to walk, or when we start to mobilize him also, make sure the fall, whatever the fall risk checklist is there, has to be covered, and he's initially mobilized with somebody's help, and then independently if he's able to mobilize.
Very good.
And if a Foley's catheter is present, to take care of his UTI, make sure that the UTI doesn't happen.
Excellent.
And also take care of his surgical site infection if he develops any of them.
All right. If you're seeing the screen, what is the first thing on the line on the list?
Delirium.
Delirium.
Okay. So remember, we see it so often in our post-op patients, particularly the elderly. So what are the things that you do to reduce the delirium?
Minimize the tubing.
Whatever you said is completely correct.
Yes,
but they're only slightly elderly oriented. Otherwise, most of the time you will do it for all patients. But in the elderly, we are talking about in this discussion. Delirium is one. Fall risk is one. I mentioned it already in the very beginning of the talk. And functional impairment is another one. So we need to think about what are the things we should do to reduce delirium.
Avoid tubings as much as possible, sir, because they're prone to pull out the tubings. So
tubing doesn't induce delirium. I agree that it has other consequences. Pain management is one. Have adequate pain management. I agree. Yeah.
Oxygenation.
Let him communicate with his family members, sir.
Get the family people around. Yeah. Again, avoid opioids. And
previous medication.
Very important. You must make sure that the day-night cycle is completely existent, as that's the word I can use, in the room. You can't have the lights on all the time. There must be darkness. Okay. And that's an important, that's the big problem. And there must be quietness. There cannot be loud noises. That's why delirium is much more common In the ICU, there is no day-night differentiation. There is always noise, always activity. Okay, so you must also look at vision and hearing aids. Remove catheters early because they're coming in the way. Substance important, psychoactive medications, as I told you, and always bear in mind, optimize the physical environment. Okay, make sure they have enough sleep, and that one of the main things is the day-night difference, and then always have family next to them. Okay, these are the 4 or 5 main things you have to do. Very acute pain and pulmonary complications we have already discussed. Fall risk, very important. There are what are called universal fall precautions. Make sure that they have their hearing aids, they have their vision, scheduled toileting, okay, appropriate treatment of delirium, because a delirious patient has a higher chance of falling, and early mobilization. Early mobilization, that's the main thing that you have to do, and get the occupational therapist and the physiotherapist involved. These are not just theory. No, we have all these facilities in our wards today, and we should try and use them. Okay. At nutrition, we have mentioned, UTI prevention, we have mentioned. We'll in fact know more about this universal fall precautions and all that as we go along. What time is it? Yeah, 9:42. Functional decline is another one that I mentioned. There are what are called care models and pathways. We will learn a little more about it as we go along. This is very important. As I said, every single ward in our hospitals must be, it's not like this, but it can be and should be like this. Uncluttered rooms, uncluttered hallways, for the patient to orient himself, large calendars and large clocks. He must know what date it is, what time of the day it is. We mentioned about early mobilization and family participation. As you can see, these are common factors that try and minimize the 3 main things: delirium, functional decline, and fall risk. These are interdependent, and these common things will make the patients get better. And as Nitya mentioned, minimize patient tether. These are the catheters and IV fluids, and restraint is something which is highly discouraged. But what I meant when I said, Nitya, these are essential things. You must take the catheters out early, I agree, but that doesn't induce delirium. That's the point I was trying to make. Yeah. Okay. And post-op delirium, as I said, we must give more attention. And so these are the things. The purpose of this slide is to get you to understand diagnosis of delirium. Okay. So I'm taking it back and asking you, okay, tell me, how do you know the patient is delirious? It's very obvious when he's rambling along and talking a lot of nonsense, there is delirium.
Yes, sir.
But what other things? There are some other things that you need to know.
Sorry, sir, I didn't get that.
When the patient is rambling and talking a lot of irrelevant things, we all know the patient is delirious.
Yes, sir.
But are there other signs of delirium, finer signs, which will tell you that this is happening, and so you can take preventive steps earlier?
Patient will be anxious and
anxiety. Okay, not convinced. Yeah. All right. Just look at this.
Attention.
Okay. Yeah. One of them is that there is a fluctuating status. The morning they're very compos mentis, they're very, very alert. Then you find that they're sleepy, altered level of consciousness. Second thing is inattention. Okay. You're talking to him, you think he's listening to him, but he's elsewhere. And disorganized thinking and incoherent. That is understood. That's very obvious. But the finer things are inattention, fluctuating kind of progress of all these factors: thinking process, level of consciousness, and attention. So when that happens, you know that the patient is going towards delirium. And we mentioned briefly 2 or 3 causes for this. Is about the diagnosis. What about the causes? What are the things that cause delirium in the elderly? Go on.
So, hypoxia, sir.
Okay.
Uncontrolled
Good.
pain.
Yes.
Electrolyte
electrolyte
imbalances.
imbalances
Correct.
and dependency,
Hypoglycemia,
preoperative
glycemia.
alcoholics.
Correct. dependent on drugs, other medications.
And
Good.
polydrugs.
Yeah. Okay. But in the elderly, always remember infection. Infection, presents in all kinds of ways. And also remember, when somebody is restless or delirious, in that sense, one of my neurosurgeons used to say, either the bladder is full or the head is full. Okay. He was saying it in the context of traumatic brain injury, TBI. But in this context, also you must remember either the bladder is full or the rectum is full. Okay, so you mentioned most of these points, but also remember, patient may have infection, urinary retention, or fecal impaction as causes of postoperative delirium. All these are correctable. And the other things that we mentioned earlier about day-night, having the family next to them, making sure that they are not tethered to the bed, having a clear, uncluttered room where they can get up, early mobilization. All these are things that you can do. As you can see, medication is not a great thing. But if medication has to be given, all right, and this slide tells all this, so I'm not going into it. The drug of choice is haloperidol. I've written very little about this because we do give haloperidol, Serinase, is the trade name many times, but much more important than the drug is all these earlier things which we have mentioned. Okay? Fall risk is always to be maintained. As I keep saying, just tell me the 4 things that I keep on saying in this talk. Anas, tell me the 4 things in the elderly I mentioned it was my second slide, second or third slide. Are you there?
Yes, sir. So,
Go on.
sir, but I didn't join the initial part,
All
sir. I
right,
was on call,
Samir.
sir.
Samir. It didn't have to be in the initial part. I've been saying it all the time because I want you guys to go home with this message. That's why I'm asking. There are 4 or 5 things that we think of in the elderly. What are those? Frailty was the first one. Samir, what are the other ones?
Sir.
Delirium was the other one. Next, I'll finish the list myself at this rate.
Comorbidities.
Functional decline
Functional decline. Next.
and fall risk.
Fall risk. Okay. Comorbidity, yes, it is there, but the main things are these. Okay, I'm repeating it. Frailty, functional impairment, delirium, and fall risk. This is what we have to keep thinking and all the time about the elderly. Okay, these are all the causes for fall that the patient may have. We have mentioned this before. So I'll let you read it for 10 seconds and I'll go to the next slide.
Sir,
Go on.
Sir, if a patient develop delirium, patient is in ICU.
Yeah.
Will you send for? Should we send for electrolytes for every patient who develops a delirium?
Absolutely. I have no doubt about it. Absolutely. Those correctable causes have to be looked into. Only then you can say it's a functional thing and not something that's because of an organic problem. Okay. Absolutely. Yeah. So I talked to you about universal fall precautions. Okay. You can read this as you read through. Okay. It's all common sense. There is no great shakes about it. The patient must know about the room that he is in. That's the first thing. The call light use, the call button should be very easily available. All the personal possessions must be within their reach. It should all be like that. I'm reminded of myself when I had a 2-month bed rest because of my fractured spine, during the fall in my Himalayan trek. And I couldn't possibly have everybody coming and giving me things that I wanted. So I had a bed with several extensions on it, a little table on the right side and one on the left side and all that. Just sitting lying down where I was, just propping up my bed, I could reach everything that I wanted, my laptop, my books, my, the remote for the TV, everything that I wanted to use. And this is the kind of arrangement that we should give for our patients. Okay. Hospital bed must be low. They should not have to jump out of their bed. And non-slip comfortable flooring footwear, flooring, night light with supplemental lighting use. Can you understand that there is nothing, no rocket science in this, but we must think about it and make sure that these are available to the patients. Nutrition is something that we mentioned. I won't go into it. It's a whole topic by itself. But there are guidelines from the, the ESPEN guidelines. What is ESPEN?
European Society for
Correct.
Parental and enteral nutrition.
Okay. European Society. You have American Society. Sorry?
Aspen, sir.
Aspen, American Society. You're right.
American.
That's there as well. So they also have guidelines. So what is important here is that you must think about supplementation of nutrition in the elderly. They will never have the inclination or the appetite or something to have the nutrition that they need. So it's not, you must force them to drink, and if necessary for a short period, you may even consider, nasogastric feeding. That's an important thing. And you'll find that supplementation, the high protein content, is very, very essential for preventing pressure ulcers, grade A kind of recommendation. So please give attention to nutrition. And I mentioned about functional decline, and this is a very important thing. You have to look at all these things, and you'll find that we keep on coming back to the same 4 or 5 common factors, which is frailty, cognitive impairment, poor mobility, mood, and other bariatric syndromes like fall risk and pressure ulcers. The whole thing revolves around these 4 or 5 components. And that's why I keep repeating it here, so that we sort of internalize it and attend to these things when we treat our patients. Okay. There are very clear programs. As you can see, there are many such, and I have given one of them, Hospital Elder Life Program, HELP. All right, all fancy terms, but if you look at what it involves, it's all again coming back to where we were and common sense features, visual aids, early mobilization, early recognition of dehydration, and things like that. And again, you can see here, promotion of family participation in care. So at the cost of repetition, I keep on repeating the same thing, but that's all there is to it in the subject. You have to attend to these things, and you just introspect and see how much of it we are actually doing now. You'll find that we will not be doing these things on a regular basis. So we should internalize these points and do it on our elderly patients all the time. Okay, there is also a whole lot of literature based on discharge planning and transition care, which means you must know whether the patient there will be a degree of decline in function, functional impairment will be there. So with that feature, can he look after himself? Can he go home? Is he living by himself? Does he have support at home? Otherwise, should he go to a halfway home? Okay. All these are beautifully done, not by doctors, but by social workers in the NHS. I could see this system working, 40 years ago when I worked, and I'm sure Ravi would have experienced it as well. It actually used to completely disappoint us, because we would have seen clinically everything is fine. Patient, after an anterior resection, bowels functioning, eating himself, nutrition is reasonable, send him home. And you will find that he will not have gone home the next morning. And you come back and see, ask the nurse, why is he still there? And they would say, okay, his home circumstances are not fit enough. So that is what they mean by discharge planning and transition. And the consultant did not have the authority to send them out. We had to have social worker clearance, and that actually impaired our work, because we had no beds to fill with new patients who needed surgery. And that's why there are such long waiting lists in the UK. We don't have that problem here. I think generally the home help is quite considerable, and we can try and do it. But even here, I always ask the family whether they're going back by themselves, and occasionally, maybe once a month, I'll come across a patient where he'll have to stay a patient who may need to stay in hospital longer. because he can get things organized at home. But as surgeons, it is our duty, particularly where we don't have such organized social worker system in our institutions. We must take care of it ourselves as consultant surgeons. 2 minutes about futile surgery, because we are going to discuss this in detail in the next class about professionalism and ethics. I want you to read up about it. If you want, I can send you some documents, but I think it's good that you search for it yourself. I don't spoon feed you, but read up about it. It's an extremely important topic that all of us must understand. Just like I'll come to you in a minute, Ravi. Yeah. Just like we have said that we should not deny surgery to the elderly just because they are elderly, it is also correct that we should not keep operating on everybody. We must use your discretion. We must use our understanding of what futility is. And first of all, we must understand what futility is. Because in this country, I find that futile care is very poorly thought of, discussed, and understood. And a lot of unnecessary or futile care is going on, not just surgery, futile care in the ICU or even in the wards. So understand, by definition, okay, the Oxford Dictionary calls it a leaky, vain, failing of the desired end through intrinsic defect. It's not just surgery. Anything futile, this is a general definition of futile. You do something for the sake of doing it, or to show off, or something like that, but it does not give you the desired end. What is beautiful is to understand the difference between effect and benefit. I will not talk about it today, because let us discuss it in the next time, in the next class. But read up about it, the difference between effect and benefit. Okay, effective treatments, if not beneficial, may still be futile. Okay, that's what the previous sentence says, but I would like you to know more about it and give me examples of effective treatments which are not beneficial when we talk in the next class. That is also futile surgery. So we come back to the first point that we raised, that Nikita mentioned very correctly. Goals of care are very, very important, both for, not just both, for all the parties concerned, namely the patient, the family, and the surgeon. A lot of conflicts occur, both in the West and even in our setup, and that's what needs discussion. But we must understand the difference between quality of life and quantity of life. Is there a point in just prolonging life when the quality perhaps actually worsens? And that is something we must understand. And we're talking about ethics again. We must understand about beneficence and non-malfeasance, doing good and doing no harm. Please understand that everything that we do has a risk, has a complication rate, and that may beat or violate the second principle of ethics called malfeasance, non-malfeasance. We may actually cause harm, and we have to take responsibility for it. And so we must think about possibility of harm when we recommend a particular treatment. And for all this, communication is the key. You have to spend time with the patient. As we mentioned earlier, look for advance directives, if any, if the patient is not in a position to communicate with you. Or if the patient can communicate, discuss the matter with him, have the family with you, have all the important members of the family with you, and communicate and spend time on communication. That will reduce your hassles, and that will help you take the correct decision. Okay? And this is a quote from my favorite teacher, my boss, who taught me my first appendix and my first hernia repair. Okay? He used to say, Krish, you have only one chance with the elderly. Try and get it right. So if you don't make the right decision, don't make the correct, carry out the correct procedure, even though you may be technically right, if your decision is incorrect, you can actually harm the patient. And that is what he was trying to teach me. Okay, thank you very much. But Ravi, before we ask for comments from others, your comment, you raised your hand.
Yeah, I think when you are talking about pre-operative or intraoperative and post-operative planning, I think what the best people would do is the nurse specialist would go to their houses, look at the home condition, whether they are staying in a bungalow or is there a where is a room for the patient and whether they can climb stairs, all these things. Planning, whether new bed has to be made or new other arrangements have to be made. In India, what we can do is to discuss these things, where the patient is going back to their own home. Is the home on, ground floor rooms available because the patient may not be able to climb,
Yeah.
and these things. So these things can be planned so that the discharge can be carried out in a much better way. And other thing we have to remember, Sania mentioned everything in the post-operative situation, but I think that the elderly probably take a longer time to come out of anesthesia. So be very careful before you give them their first feed, because risk of aspiration is high. So
Yes.
they have to be completely alert and awake before you feed them. Though it is important to feed them, but it is important to be aware of that fact.
Very true. Okay, so comments and questions, if any, from our students. First years first, second years first in the hierarchy, and we'll come to the registrars in the last. No questions?
Ainas, come on. Hello, Ainas?
She may not be there. She's on call or something. Yeah.
No, sir, no.
Hello.
Okay.
Yes, sir.
Go on. Any comments?
Comment.
Questions?
Sir, very extensive class, sir. I learned a lot.
Okay. Tomorrow day after tomorrow, I'm going to ask you again. What are the main factors to be remembered about the elderly? How much do you think you would have forgotten? Not just you, every student, including me. How much do you think you'll have forgotten by day after tomorrow? Any guesses?
40 to 60%.
Correct. 40% you would have forgotten by day after tomorrow. Okay. By the end of the month, you would have forgotten 60 to 70%. So what is the solution for that?
Repetition.
Repetition.
Right.
Okay. Listen to this
Practice.
talk let's listen to this discussion on the YouTube again. All right. Okay. Fine. Final comments from
Sir,
go on.
the thing was there are no Indian guidelines for geriatric things, sir. Because
agree.
searching because you would ask particularly about Indian scenarios and all.
Correct. You got away with it because I also searched for it and I never got it. I also searched for
Because I think geriatrics in India is a very nascent specialty.
nascent specialty. So that's why I sort of modified each time and kept on saying that, this happens in the West, but doesn't necessarily happen here. And so the lesson to learn is in the West, a consultant surgeon doesn't think about these things because the social worker or the nurse practitioner would have thought of all this. In India, we have to think about it and do it ourselves. That's all. That's all there is to it. Okay, Nitya, your comments.
So, a very interesting topic, sir. So, it was nice. And I think we should start putting these things into our practice.
Yeah, music to my ears. Do that. It's very, very important. You guys can take the lead. You and Sania can take the lead and have a case sheet or a checklist for the elderly over 65. Use a checklist. You prepare one yourself.
Sir,
You can get a paper out of it in no time. Yeah.
So there are already checklists in the file.
Yeah.
Nurses take care of it, sir. Fall risk and nutrition assessment.
Okay. You have other things also.
Yes, sir.
Good. You incorporate it in your checklist. There are many more that I mentioned. Put all of them. You make a checklist yourself, and you will have a paper by the end of 6 months. Yeah. You have to do it. That's all. Yeah. Final comments from Sania, and we are off.
It's a very detailed, very nice class, sir.
Okay.
Enjoyed the class.
All right. Okay. Ravi, anything else to say and add?
No, I think it is just a very neglected topic. I think it's good that it was highlighted.
Yeah.
And more important is, as I said, because the support system for us is not available, we'll have to be conscious of that fact and arrange these things ourselves.
Yeah. All right. Thank you very much. Good night, guys.
Good night.
Good night.
Good night.